There are many different combinations of redo TAV possible, but when thinking about the challenges and techniques for coronary access, we can break it down into these four groups. The challenges can be seen across any combination of redo TAV, from the neoskirt to leaflets, as well as cell and commisural misalignment. But when thinking about tall frame THV in the setting of redo TAV, all the challenges and barriers for a coronary catheter are actually centrally located. Therefore, if you were to adopt a conventional cannulation approach of coming down to the middle and rotating into the ostium, you'd be more likely to engage with and interact with some of the challenges. Therefore, one approach would be to deflect the catheters down the side, avoiding the central portion. As you can see here, so we have an evolute inside of a sapien, and you can see how the catheters are deflected down the sides, avoiding the central portion. Another approach is this is the inner curve approach, and in this particular example we have a sapien implanted low inside of an accurate, and you can see the catheter is coming down the inner curve of the aortic arch, entering the sinus and engaging into the left coronary artery. Now the particular catheter that's being used here is actually a Judkins left 6 catheter, which may sound a little bit unusual. But if we look in a bit more detail, normally when we go from a JL 3.5 right the way up to a 4, 5 or 6, we upsize the Judkins left because we have a dilated aortic root. And that's because we use the difference between the primary and the secondary curve of the Judkins catheter for its horizontality. But in this technique, we're using that difference between primary and secondary curve for its verticalness. This is another technique. This is the outer curve approach, whereby you come along the outer curve of the aortic arch to drop down into the sinus and engage the right coronary artery. Now, the particular catheter used here is an internal mammary catheter. And if we look at the difference between the Judkins right 4 and the internal mammary catheter, you can see that the internal mammary has a narrower turning radius and also has a more sharp bend. This allows you to drop it into the sinus between narrow gaps between a valve frame and the, let's say, sinotubular junction, and rotate into position for coronary access. Finally, in this particular setting with accurate and sapien valves, you can see here if you adopted a conventional internal approach, there's a very short gap between the neoskirt and the STJ, and it appears unfeasible to access. However, with this particular combination of valve frames, the open cell arches allow you to drop down into an adjacent sinus, and you can effectively wrap around the valve frames of the complexes in a lateral approach to achieve the coronary access. Finally, for the take-home messages, here are the 5 steps to consider for coronary access after redo TAV.